righty, so I will give my best to convince you. Should consolidation therapy and MRD testing be used for monitoring multiple myeloma? There are some issues with it. Okay. I mentioned already that I'm in favor to do MRD testing for the treatment of multiple myeloma and subsequently consolidation in order to achieve this. When we talk about MRD testing in multiple myeloma, we talk about a variety of different tests. You can see here that this includes also the antisense oligonucleotide PCR, VDJ sequencing, exome sequencing, and flow cytometry. I hope you can hear me. There are some issues with the different tests, and we really have to focus that those tests give us the appropriate sensitivity, reliability, that we can study clonal evolution, that we can overcome sampling error, that's a big problem in multiple myeloma, and that we also avoid the inter-observer variations. So doing this debate for me and preparing that debate had a little bit for me of, do we argue for cure or do we debate between cure and control? When you really argue in favor of cure, then you have to aim for MRD negativity. I think we all agree that cure in multiple myeloma is only possible if you eradicate a disease. In case you go for control, then you accept probably MRD positivity. So, but why not going for a cure in multiple myeloma? Why don't we do this? Why, in contrast to all other cancers, we are okay with partial remissions? Would you ever remove just half of the breast tumor in a patient and wait until you have kind of, the source for a relapse, and you just prolong the overall survival? So saying this raises the other question, is it possible to cure multiple myeloma? You know that we argue forth and back, especially with Bart Barlogi. And so far, we did never assume that cure is possible. But we showed that, yes, it is possible. The proof of principle has been shown by allogenic transplant, but this was only possible with the eradication of minimal residual disease. I show you here a work from PAVA, from a group who did an allogenic transplantation, and you can see that for the first time they were able to achieve a plateau in the overall survival and in the progression-free survival. This is usually unheard of in multiple myeloma, since usually our curve really declines. But also, we have seen that with the newer agents, we can achieve a better clinical response, and especially Lola Landgren showed that giving CRD, carfilzomib, Revlimid, and dexamethasone can induce MRD negativity and achieves response rates up to 100%. And also Kapoor from Maury Gertz from the Mayo Clinic showed in a very important paper the importance of a good clinical response. They analyzed over 400 multiple myeloma patients who received a stem cell transplant within a year after their diagnosis. And they showed very nicely, as you can see here, that the complete remission was really significant for the progression-free survival. But you can see also that the overall survival significantly increased in patients who achieved a complete response or better. So the question is, why stop at the complete remission when the myeloma is still responding? Patients do not have major toxicity and the disease is not eradicated. Why do we stop here if we have a complete remission or in a near complete remission when we always have 100 million myeloma cells still left in the patient? We could go for MRD negativity, and that would be the first time that we go for cure with this MRD negativity. So Dr. Kapoor from Maury Gertz group further showed and analyzed what is the effect or what is the impact of achieving a stringent complete remission. You can see here in comparison to a complete remission or a near complete remission. So you can see that the median progression-free survival significantly increased in patients who had a stringent complete remission with 50 months versus 20 months and 19 months in patients without a stringent complete remission. So the median progression-free survival almost doubled. But looking for the 5-year overall survival, you can see that the stringent complete remission increased to 80% in comparison to 53% and 47% in a complete and near complete remission respectively. This difference was highly significant, and I think it really shows the importance of a stringent complete remission. Moreover, it also questions what is the prognostic value of achieving an immunofixation negativity if we are don't see any really striking differences between complete remission and a near complete remission. But Dr. Kapoor also analyzed the incomplete remission patients, the impact of MRD negativity. And you can see very nicely here that patients who have a complete remission and MRD negative have the best and a significant better progression-free survival. Also for the overall survival, I think this is pretty striking that there's a significant difference in complete remission and MRD negativity. Another group from the UK, Rostrom, analyzed the MRD status in patients with adverse and favorable prognostic markers. And he could show that in patients who have favorable cytogenetics, MRD negativity increases the overall survival, but even for patients who have abnormal or have adverse prognostic markers in terms of cytogenetics had a benefit of MRD negativity. It's not only important to achieve a stringent complete remission, it is also important to maintain the stringent complete remission. And this was also shown in the paper by Kapoor. They showed that patients who have a sustained stringent remission have an excellent overall survival, which was not reached at a 2-year landmark analysis. And the difference between the non-sustained stringent complete remission and the sustained stringent complete remission was highly significant. This is a trial by Pava from the Spain group, and it was just published, and it's still pre-publication, and it summarized the most relevant studies based on multi-flow color for the detection of multiple myeloma. And you can see a variety of studies with a high number of patients who focused really on the effect of MRD negativity, showed that MRD negativity increases or significant increases the progression-free survival. Most of the studies showed also a benefit for the overall survival for patients who were MRD negative. And this is already almost my last slide. This is also from the same group, and they published that recently in Blood. They asked what level of response is really necessary to achieve a long-term remission. And I think they showed very nicely, if you go for a partial remission or a VGPR, you can see that the amount of tumor cells still left in our patients gives seed or is a source for a relapse, which occurs faster. So only really a deep remission with the goal of the eradication of minimal residual disease is a precondition for achieving a long-term remission. So, but I also need to talk, or I also was supposed to talk about consolidation therapy. So I think that one is a precondition for the other. If you really go for MRD, you have possible negativity, you have possible options to achieve this, such as transplant, maintenance, but also consolidation. But Antonio Palumbo showed very nicely in his GEMA trial that consolidation can decrease the residual tumor burden. So what he did in patients with a near-complete remission after autologous stem cell transplant, he gave patients 2 cycles of a consolidation therapy with either VTD or TD. And you can see very nicely that, again, the PRC negativity increased in patients who received VTD 2 cycles of consolidation from 43 to 76%, and TD from 37 to 52%. This was highly significant. So there was a 5-log median reduction of the tumor burden, speaking for consolidation therapy. So in summary, we have to say that with novel treatments, we can achieve deeper responses in patients. Deeper responses means, and I showed you that in several trials, that we see better survival. So MRD negativity is, that's why, in my opinion, the only way to achieve a cure or long-term control. So why not aiming for this if we have the abilities? And keep in mind, I'm not talking about the 80-year relapsed patient who is in a bad condition. We are talking about younger patients who are diagnosed with multiple myeloma and transplant eligible. So MRD needs only to be achieved, but we also need to maintain MRD. And the best method for the MRD negativity to determine needs to be defined, but I showed you already that there are multiple options. So I would like to stop here, and I look forward to my opponent, Dr. Loniel. Thank you.